Hi, everybody. I'm Dr. Tonya Cremin, and this is Jessica Iannotta. And today we are doing part two of our series on living your best life during menopause and beyond. I just briefly am a local integrative and osteopathic family physician. I'm no longer doing primary care, although I've done primary care in the area for many years. I've had a private practice here for over 15 years at this point, right here in Monroe, previously in Trumbull. I'm currently focusing on osteopathic and integrative medicine. My contact info is at the end of my presentation, and I can help you with all different kinds of concerns. But tonight, of course, we're talking about menopause.
And I'll give a brief introduction as well. Hi, everyone. My name is Jessica Iannotta. I'm a registered dietitian, and I've been a registered dietitian for over 20 years and worked in all different kinds of settings. But currently, I've recently opened a private practice here in Monroe, right in the same office as Dr. Cremin, and it's called Westminster Nutrition. And I'm also specializing in women's health, so have a passion for helping people, and I look forward to sharing a lot of great information with you in this part two of our series.
Because I want to try to keep this short. I packed so much information. Oops, Luca, can you turn sharing on for me? Or Jessica, can you turn sharing on for me?
Try now. I think it should work.
So, uh, so many different types of symptoms happen during the menopausal transition that a lot of women come to me and think that they're just going crazy. So that's why I named my talk, Am I Going Crazy or Is It Menopause? So today we're going to talk about some of the less well-known symptoms of menopause, in addition to the typical symptoms such as hot flashes, and stopping your period. And then we're going to discuss some ways to manage these issues from an integrative standpoint, which includes conventional medicine, medication, lifestyle changes, and complementary and alternative approaches to care. So before I get going, just want to mention, feel free to go ahead and put any questions in the chat, and then we'll address them at the end of the talk. So menopause is a naturally occurring transition for everyone who is born with ovaries and a uterus. Uh, it- the ovaries stop producing estrogen generally around the age of 50. The average age for menopause is 51, and it creates a low estrogen state, which results in a variety of symptoms because of that lack of estrogen in our bodies. And a lot of times, it's difficult to determine if these symptoms are because we're getting older or because we're lacking estrogen. So, symptoms that are pretty well known, I think, are hot flashes, and anxiety and depression, sometimes increase during the time of menopause. Other changes that people might not be familiar with are memory changes or cognitive changes, issues with concentration. I'm going to talk about all of these a little bit more in detail later. Sleep disturbances, weight gain or change in distribution of your weight from the hips and thighs pre-menopause to the abdominal area, your belly, after menopause. The genitourinary syndrome of menopause, sexual dysfunction, and changes to skin and hair. Those are all quality of life issues that happen during menopause. But then, from a medical standpoint, we have health concerns that happen because of that lack of estrogen as well, including osteoporosis, cardiovascular disease, such as heart disease and stroke, high blood pressure, high cholesterol, cancers. These issues can often start before the final menstrual period, and they differ from person to person. There's no one single menopause syndrome. Everybody has a different experience. You might have an experience similar to your mother or sisters or aunts. So if you think that you're starting to go through menopause, you can always ask them when your mom in particular, when her last period was, how old she was, and you're probably going to have it around the same time unless you have a medical reason to stop sooner. So the most common symptoms of menopause that most people are familiar with are what we call vasomotor symptoms or hot flashes. Hot flashes and night sweats are really the same thing. They happen, we don't really know exactly why, but they happen when our estrogen levels drop in our body. So sometimes if a woman is perimenopausal, meaning she hasn't had that last period yet, and her estrogen levels are going up and down during her cycle, she might have certain times during the month when she notes she's having more hot flashes and other times when they go away for a little bit. They are often accompanied by sweating, chills, anxiety, heart palpitations. Those are more severe symptoms with hot flashes. For some women, it's just a very simple, is it warm in here? Or, gosh, are you a little hot? But for some women, they can have really severe symptoms where they feel like they've flushed from the waist up, beet red, sweating profusely, and really uncomfortable. So, the number of episodes varies from person to person. They tend to be worse during those years just before the last period and just after the last period. And the duration of hot flashes really varies from person to person again. For some women, they might not have any. There are certain cultures around the world that they don't really experience them at all. Those are few and far between. Most people do. But there are others where it's 10 years and beyond, even up to 20 years of symptoms. And that's a very low number of people, less than, or a little bit around 10%. So I have a little chart here of triggers. Anything, I like to say heat begets heat. So anything that's going to make you feel hot is a good chance it's going to bring on a hot flash. So hot weather, warm environments, wearing heavy clothing, drinking caffeine or alcohol, eating spicy foods, stress, drinking hot beverages, taking hot showers or baths, or smoking cigarettes too. So risk factors that increase the likelihood of hot flashes would be excess weight or weight gain. So even if you're at a normal weight, but you've recently gained weight, that might bring on more severe hot flashes. Smoking or vaping, stress, you see a number of issues here that are related to stress in general, financial difficulties, medical conditions, high anxiety. Plus education, and then your diet plays a role too. And I'm sure Jessica's going to talk about this a little bit later, but high fat or high sugar diets can play a role. And certain medical conditions can increase the risk for hot flashes, such as thyroid disease, diabetes, for instance. If you have your ovaries removed surgically, that's going to automatically bring about menopause. And so hot flashes can be pretty severe in those instances because oftentimes those are younger women and their hot flashes can be debilitating. So I want it to be clear that oftentimes women can, or people can have hot flashes that aren't related to menopause, and you really want to see your physician. If you have thyroid disorders, if you have an infection, if you have cancer, or certain other conditions that you might not be familiar with, such as pheochromocytoma, which is an adrenal disorder, and carcinoid syndrome, which is a type of cancer, you want to go see your doctor. I want to be clear, if you have been menopausal for a few years and your hot flashes weren't that bad, and then all of a sudden they got worse, please go see your doctor because you want to be evaluated. Or if they're accompanied by nausea, vomiting, diarrhea, weight loss, heart palpitations, fast heartbeat, flushing, which is kind of the same thing, but it could be your whole body, or a headache that won't go away, absolutely, please go see your doctor. So moving on to the genital urinary syndrome of menopause, that involves symptoms concerning the vagina, the vulva, the bladder, and the urethra, and that can't be attributed to a different diagnosis. So these, when they are related to menopause, really won't go away without estrogen. And so that's kind of a simple approach. We can just use topical estrogen creams or local estrogen treatments that I'll talk a little bit about more later. So the tissues in the vaginal area might seem a little bit thinner and deflated. And this is really common. About 50% of women have these symptoms, and 30 to 40% of women have urinary symptoms related to the GSM as well. The most common symptoms that a lot of women are familiar with are vaginal dryness and pain with intercourse, also known as dyspareunia. And it can also increase the risk of urinary tract infections or recurrent urinary tract infections because the protective tissues in the area have thinned out so much. So this picture is a view of what we would see under the microscope of healthy tissue, which is getting lots of good estrogen flowing through it. On the left, we've got it's nice and puffy, lots of bumps and folds. And then as we age, it all flattens out and gets thinner and isn't as protective. So different changes you might see are thinning or loss of pubic hair, thinning or fusion of the labia, retraction or fusion of the clitoris, and then posterior fissuring, which means breaks in the skin that might happen at the vaginal opening closer to your rectum. As I mentioned, in the vagina, the tissues become thinner, smoother, and can retract. You might get discharge that you didn't have in the past. The pH changes, which can increase risk of certain types of vaginal infections. And then on the flip side, as opposed to discharge, you might get loss of vaginal secretions and cervical secretions, which results in vaginal dryness. This thinning of tissue, the urethra is the opening from your bladder to the outside of your body where you urinate from. And so when that opening is more open to the outside, it's in addition to the thinning of the tissues, an additional increased risk for urinary tract infections. So I mentioned the symptoms again. So we can end up with dryness, itching, burning, irritation, vaginal discharge, pain with urination that might not be a urinary tract infection, increased urination at night, increased frequency of urination, and recurrent urinary tract infections. The sexual symptoms include decreased lubrication, decreased arousal, pain with intercourse, decreased or delayed orgasm, and then bleeding after intercourse. So causes of genital urinary symptoms that aren't related to menopause are multiple. So if you're having some of these symptoms, please just go see your doctor because you don't want to assume anything. And then once you're familiar with the changes and what's happening and you've been reassured that it's menopause that's causing your symptoms, then you move on from there. But different things that touch your skin, just like anywhere on your body, the skin in the vulvovaginal area is very thin and sensitive. So you can end up with contact dermatitis from soaps, laundry soaps, bath soaps, things like that. You can end up with candida, yeast infections, other types of vaginal infections that you might not have gotten in the past because of those pH changes we mentioned. Overactive bladder, if you're leaking at all, that urine constantly streaming onto the skin can be very irritating, and then a whole host of other issues. And again, never assume, always see your physician. So other common menopausal symptoms that you might not be as familiar with are issues with sleep, insomnia, mood changes, changes in your memory and ability to have word recall, forgetting things, muscle and joint pains, skin and hair changes, weight gain or changes in distribution, like I mentioned before, headaches or migraines, and decreased libido or interest in sex. So sleep disturbances in menopause, this is one of the biggest issues that women come to see me about. So the symptom is difficulty sleeping. Insomnia is the disorder. It's very common during menopause. Night sweats can cause disturbances of sleep very commonly. And sometimes women don't realize that they're having them, but they just come in because they're not sleeping well. so that you're alert, but they might be enough to bother you so that you don't have deep sleep. And the highest rates of sleep issues are during that late perimenopausal issue in the year or two just before that last period, or during surgical menopause, as I mentioned before, when those ovaries have been removed for some sort of medical reason. So, of course, other things can contribute to sleep problems, including stress, aging, caffeine. Little plug, caffeine has a 7.5 hour half-life, so you might notice as you get older that you can't have caffeine late in the day. Like, I know a lot of people have a habit of having a cup of coffee right after dinner, but as you get older, even if you can fall asleep, if you're waking up in the middle of the night, that little bit of caffeine still might be enough in your body to wake you up. There are certain drugs and alcohol, poor sleep health, and medical problems as well. And of course, issues such as sleep apnea, restless legs, thyroid disorder, diabetes, anxiety. Again, if you're having a lot of sleep problems, go see your doctor so we can all help you sort it out. So, of course, I think most of us know if we don't get a good night's sleep, you're more likely to be cranky, irritable, might have more pain, and just not get through your day as well. Something you might not be familiar with is the fact that when you're not getting a good night's sleep on a regular basis, it can make it more difficult for you to lose weight and you can actually gain weight. And poor sleep, in particular from sleep apnea, can increase risk for cardiovascular disease, heart disease, and strokes. So one thing I want to focus on really briefly, which I think is super important and always the first thing I talk to my patients about, is sleep hygiene. Sleep hygiene is just making sure that your sleep space and environment is most able to help promote a good night's sleep for you. So you want a very quiet room, add a fan or something with white noise. You can actually get white noise apps to put on your phone as well. Make sure you sleep when you're tired or sleepy. Don't force yourself to stay up. Using your bedroom just for sleep and sex, wearing lightweight sleepwear and then piling on the blankets if you're cold, avoiding heavy meals, don't eat within a few hours before bedtime, alcohol, caffeine, nicotine, chocolate. Exercise is important. Early in the day is best, definitely not within 3 hours of bedtime, because even though you might fall asleep again, it tends to wire people up before bedtime. And getting yourself into a sleep routine within that hour before bed, turning the lights down low, getting off your phone. Don't watch TV, maybe nothing, don't go to bed reading a really engrossing mystery book or watching the news, I also think is a bad idea right before bed. And then avoiding naps, unless they're really short, quick cat naps, 15, 20 minutes if you're really desperate in the middle of the day is fine, but anything longer than the half an hour can impact your ability to sleep at night as well. So interestingly, the first line treatment for insomnia is actually cognitive behavioral therapy. So therapy with a counselor or a psychotherapist. So they do an evaluation to determine what kind of things are going on in your life that are creating problems in your sleep. And they can help you put together a program to make some behavioral changes in your life so that you can get a better night's sleep. So there haven't been any studies comparing the benefits of CBT and hormone replacement therapy, but we still know that it's very good. So Stanford and Yale work together and they have a website that has some great CBT approaches for insomnia. I'm not sure if they have an app, but it's worth looking, and it's called thesleepreset.com. So you might want to take a picture of that page or write it down. And then there's some apps. There are lots of apps out there to help you with sleep, but Calm and Headspace, meditation apps, things like that can be really beneficial as well. So, some non-medication treatments for sleep issues. Melatonin, people talk to me about a lot. So, the research on melatonin is best for people who are dealing with jet lag. A lot of people swear by it, but in the long run, studies don't show that it's really that beneficial. except for shift workers. So for people who work maybe overnight shifts on a regular basis and then they have a vacation and they want to change their sleep schedule, it's best to take melatonin 3 to 5 milligrams about an hour before you want to go to sleep. And that can be beneficial in that way. If you have OSA is obstructive sleep apnea. If you have sleep apnea, you definitely need to use either a dental device or a CPAP machine. Please talk to your doctor about that. Make sure you're using those. And then exercise, mindfulness, yoga, and acupuncture. A lot of people swear by these things. My patients absolutely find acupuncture can be really helpful for them, and I do that in the office. But the studies are kind of mixed on all of those things. So there are lots of medications that can be used for sleep. I'm not going to go over all of these in detail. There are many antidepressants that can be used. There are specific sleep-focused meds like ropinirole, and then the Z drugs like zolpidem and Zolpidem, Ambien, for instance, are well studied and approved by the FDA to treat insomnia issues. Benzodiazepines like Xanax and Ativan, alprazolam, lorazepam are not the best medications to use. And I'll refer to them again in a second, something that was surprising to me, but lots of people do use them. So hormone therapy and sleep, we don't have hormone replacement therapy FDA approved to treat insomnia, but both estrogen and progesterone, EPT is estrogen, estrogen and progesterone therapy, both, excuse me, of them have been shown to help with sleep overnight. In particular, progesterone has been associated with improving sleep by stimulating those benzodiazepine receptors, or the receptors in our brain that latch on to Ambien, to the alprazolam, Xanax, for instance, and they can cause quite a significant sedation. In fact, a personal story, I'm taking progesterone at night. And I changed my dose to a higher dose recently with my doctor. And I took it a couple of hours before I went to bed. And within in an hour, I felt like I was drugged. I was so surprised how strong the effect was for me. So I just changed it to right before bedtime. And then everything was fine. And it does help me sleep really well. So next, I want to move on to depression and anxiety. Um, I just want to point out that perimenopausal women are twice as likely to experience symptoms of depression compared to premenopausal women. Please seek out help. I don't go into depression a lot for this because there are so many different ways that it can be addressed, but depression can be really debilitating and anxiety as well, and you deserve to get help. So many different things play a role in depression. In particular, a personal history of depression in the past is the factor that is most likely to increase your risk for depression during perimenopause. But poor health, sleep disturbances, changes in your memory, changes in weight, your appearance, stressful life events, all of these things can increase risk for depression. Cognitive changes, cognitive decline leading to dementia is a common concern during the menopausal transition, most likely forgetfulness, word recall, ability to retrieve information, and concentration. But I have good news. The ability for new learning and responding to information is not affected that much. So you can still teach an old dog new tricks, okay? We still have the ability to learn just fine. And any of these issues that occur with memory in that perimenopausal period, as your hormones are flip-flopping all over the place, they tend to settle down after that last menstrual period, within that year after the last menstrual period, and people get back to their baseline. Muscle and joint pain is something that you might not be so familiar with regard to menopause. Estrogen is a wonderful anti-inflammatory. And so when women go through that menopausal time, a lot of times they just feel achy and sore and they really don't know why. And when we research it, there's really, do x-rays and such, there's really no reason other than aging and menopause. So first line treatment would be exercise. The orthopedic surgeons like to say motion is lotion, losing weight to get into a healthy weight range, and analgesics or, over-the-counter pain medications like Tylenol or Motrin. However, if your pain it just keeps going, it's severe, or we can't figure out a reason, you might want to try some hormone replacement therapy, and it's worth talking to your doctor about it. And of course, we need to rule out other causes like injuries, rheumatoid arthritis, other rheumatologic disorders, vitamin D deficiency, hypothyroidism, other endocrine disorders, and other rheumatologic disorders. So skin changes in menopause are because of decreased estrogen. 60% of women report skin problems. Common symptoms are dryness, itching, thinning, wrinkles, sagging, poor wound healing, crepey skin, cancer or precancerous lesions, dark spots, and then low self-esteem. So factors affecting skin changes are genetics. So if your mom had severe wrinkles, as she was going through menopause or after menopause, there's a good chance you're going to have those changes too. If you have a family history of very dry skin, you're probably going to have those changes too. We can protect ourselves though by wearing our sunscreen, by avoiding smoking and smoky environments, by limiting our alcohol consumption, avoiding pollution, eating a healthy diet, getting a good night's sleep, and taking estrogen if it's appropriate for you. Hair changes in menopause. So many women come to me complaining about their hair thinning or falling out. There are a lot of different reasons that this can happen, and they're not always related to menopause. So again, it's a good idea to go and see your doctor to rule out any kind of um, medical problem that could be contributing, such as thyroid disease, which is a common one. Vitamin disorders also can play a role in hair loss as well, and certain infections. So reduce hair growth on scalp. You can end up with hair falling out in clumps. A lot of times that can be related to a viral infection too. Post-COVID, a lot of people have their hair falling out in clumps, and it gradually does come back. And then on the flip side, it grows where you don't want it to. So chin hairs can be very common, in particular in women who've gone through menopause. So again, we talked about systemic diseases like hypothyroidism. There are certain medications that can cause your hair to fall out as well. Diet, again, plays a role, genetics, and just aging in general. Weight, another big one people come and talk to me about. So the bad news is, or the good news, I think, that you actually have a lot of control over this in a lot of ways. So it's really the weight gain is primarily related to decreased activity and changes in your diet. So a lot of women insist that they haven't changed what they eat. However, um, if they're not moving around as much as they did 5 or 10 years ago, then your metabolism is going to drop and your lean muscle mass will drop and you'll be more likely to gain weight. So sleep disturbance also can change a lot of your hormones that are other hormones that are in your body and increase risk for weight gain as well. Decrease in lean muscle mass because you're not moving as much can play a role. So you want to increase your protein intake and participate in weight-bearing activity to avoid loss of muscle mass. And then, yeah, as I mentioned, decreased physical activity can play a role. Headaches and menopause, lots of differing issues. Number one, if you have new headaches or your headaches have changed, please see your doctor. If they've gone away, that's fine. You don't need to see your doctor. But if the headaches that you ordinarily have changed significantly, then you absolutely want to go see your doctor for them. So, women who have migraines without aura often notice a decrease during menopause, and women who have premenstrual migraines often have them completely go away with menopause. So, that's great news. And then there are categories of including primary headaches, such as migraine and tension headaches or cluster headaches. And then there are headaches that are related to other issues that you absolutely want to rule out. So, sexual dysfunction in menopause, it is not just you. It is very common, and they often are undiagnosed and undertreated. Please talk to your doctor. I want to assure you, we have heard everything. Please do not be embarrassed. And if you have a physician that you don't feel comfortable talking to, please find somebody else. So important to feel comfortable with who's taking care of you, okay? So 40 to 50% of women report at least one sexual problem, and these are very commonly pain with intercourse, low libido or lack of desire, difficulty with arousal or achieving orgasm. And this is commonly related to emotional issues, social problems, and relationship conflict. So you can see this massive list of issues that are associated with sexual dysfunction, from actual medical problems to stress, anxiety, history of trauma, social influences, and your relationships. If you're not getting along well with your partner, there's a good chance you're not going to want to be physically involved with them as well. So, menopause symptoms and sexual desire, if you're just not feeling like yourself, it can absolutely decrease your interest in sex. But hot flashes, difficulty sleeping, if you're tired, if you've gained weight, if you have mood swings, these can all play a role in your sexual desire. And of course, the loss of hormones, the estrogen, can be associated with low libido and decrease in orgasm. So a lot of women are asking currently about testing for testosterone in particular, but we really don't have good data on what the levels should be in women postmenopausally. And so it's really not recommended and isn't used to guide treatment. I will talk a little bit more about testosterone in a minute. So, some treatment for sexual disorders. For pain with intercourse, there are a lot of things that you can do on your own. Over-the-counter vaginal lubricants would be a first step. You use them at the time when you want to be sexually active. Vaginal moisturizers build up over time, so those are also available over the counter, and you can go ahead and use them every single day, and they help build up. You can use them in combination with lubricants. To help stress the tissues, massagers such as dilators or vibrators can be helpful. And then there is medication. So estrogen, local estrogen, such as vaginal inserts or creams, can be used. DHEA is an androgen that I referred to in a previous slide. That is, we have a prescription for that does help with dyspareunia or pain with intercourse, and then we have some other medications as well. You can also consider pelvic floor physical therapy. We do have physical therapists in the area just down the road in Trumbull in particular, who specialize in physical therapy for women, sexual disorders, and can be really helpful for a lot of people. So for low libido, HSDD is a hypoactive sexual desire disorder. If you have low libido, I want you to know it's only a problem if you think it's a problem. If somebody else in your life thinks it's a problem and you're happy with the way things are, it's not a problem and you don't need to follow up on it. But I know that these can create interrelational issues, and it's certainly fine to reach out and talk to your doctor. So there are sex therapists, there are sex specialists, some OBGYNs are sex specialists, and other physicians as well. So it might include sex education, individual or couple sex therapy, treatment of other issues, including medication. And testosterone and DHEA can both be used for HSDD. For difficulties with arousal and orgasm, sex therapists, again, can talk about anatomy and physiology of orgasm, help you learn about vibrators or other sex toys, and other types of interventions. There is a great book out there called Come As You Are by Emily Nagoski. And I recommend that highly to help you understand what is normal. Pretty much everything is normal, just FYI, and can really help. It gives a lot of really wonderful information. Okay, so hormone therapy for sexual function. I want you to know that sex is 99% mental. So if you have relationship issues, physical and mental health issues, those are more important than estrogen levels or menopause when it comes to your sexual health. Um, However, estrogen replacement therapy, if it helps you, and progesterone, if it helps you get a better night's sleep and you have more energy, then you might be more interested in sex. If you have tissues that have thinned out, that are atrophied in the vaginal area, local estrogen, those creams and inserts and gels that I mentioned before, they help puff up those tissues within just a couple of weeks and can make a big difference, can even increase lubrication. So that can make a big difference in your sexual function and interest. And then with the treatments, if your hot flashes are better and you're not having night sweats, that can play a role too. So a little bit about testosterone. So we don't have any FDA-approved female testosterone product. So currently, people who are prescribing testosterone are using male testosterone products in very, very low doses. There are some compounded products, but we don't usually recommend those unless you have issues with the carriers and the creams and the gels in general, because compounded products are not FDA regulated. And so sometimes there can be difficulties with making sure you're getting what you're supposed to get and the dose that you're supposed to get. If you are taking testosterone, your levels should be checked every 6 weeks, or 6 weeks after you start the testosterone therapy, and then every 6 months after that to make sure that you're in the normal premenopausal range for women. And we don't really know, everybody who's using testosterone as a woman currently is really, you're participating in an experiment because we really don't have any long-term safety data. So when is hormone therapy appropriate? It's effective and FDA approved for hot flashes and night sweats. Otherwise, it's effective for vaginal symptoms, bladder symptoms, premature menopause. If you go through menopause surgically or before the age of 40, you should really advocate for yourself and request hormone replacement therapy. It's absolutely appropriate. And it can also help prevent bone loss. So systemic hormone replacement therapy has higher doses for hot flashes and bone health. If you have a uterus, meaning you didn't have a hysterectomy, you need to take progesterone to protect yourself from endometrial cancer as well. It's safest in women who start it within 10 years after that last period and women who are under 60. If you start hormone replacement therapy before the age of 60 and you're doing fine with it, you generally can continue it pretty much indefinitely, FYI. So that's good news. I've had a friend of mine say that they will pry it out of her cold, dead hands. She's an OBGYN locally. So as I mentioned before, there's local vaginal estrogen creams, inserts, and tablets. Those are very low doses. They're safe even in women who have had breast cancer. So definitely advocate for yourself and ask for that. So they are not effective for preventing heart disease or dementia. They're not effective for weight gain or hair loss, and they're not shown to be effective for musculoskeletal issues like arthritis. However, they may help with those menopause-related aches and pains. Testosterone therapy is indicated and appropriate for low sexual desire if it's diagnosed as a disorder, but absolutely please talk to a menopause specialist to weigh the risks and benefits. So different categories of hormone replacement therapy. I went over these in the last talk, but just briefly, the estrogen therapy is unopposed systemic estrogen or vaginal estrogen. Estrogen, progestogen, or progesterone. Progestogens are artificial lab-made. Well, all of it is made in a lab, but progestogens are similar to progesterone, but not exactly the same. That reduces risk of endometrial cancer because of unopposed estrogen. Some women can just take progesterone. And then we have other types of medications that are non-hormonal. Duavi is a newer medication that has estrogen and bazodoxifene, which is not progesterone. And then SERMs and DHEA can be a good one for women who have HSDD. So, in summary, non-hormonal treatments for menopausal symptoms, hypnosis, cognitive behavioral therapy. There's a medication called Veoza, which is non-hormonal and targets the brain to reduce hot flashes. So that's safe in pretty much anyone. Gabapentin is a medication that's been used for seizures, but also used for chronic pain, and it has been shown to reduce hot flashes and help with sleep. Oxybutynin is an old medication that we've used for overactive bladder for decades, but has been found to reduce hot flashes. And then antidepressants like SSRIs and SNRIs have been shown to help manage, so you can kill two birds with one stone in that regard if you have issues with depression or anxiety. Something called a stellate ganglion block is an injection at the front of your neck, which can help with vasomotor symptoms when they're severe. Weight loss can help. And then there are some other more integrative approaches that are not recommended by the North American Menopause Society because we don't have great scientific evidence. However, lots of people swear by them and they can be beneficial. So absolutely worth a try if they're appropriate. So acupuncture, herbal supplements such as black cohosh, and certain exercises as well. Always, always, always talk to your healthcare provider, physician before you start any kind of new treatments or supplements. And then some over-the-counter treatments and self-care. Again, I went over these the last time, but about vaginal lubricants and moisturizers, over-the-counter sleep aids, layering your clothing, sleep lightly, the apps, guided imagery, hypnosis. You can find a lot of good things online. Lifestyle approaches: get a good night's sleep, don't smoke, reduce your caffeine intake, reduce or eliminate alcohol and other substances, eat a plant-based anti-inflammatory diet, and exercise 30 to 60 minutes most days of the week. This doesn't mean you have to be sweating it out. You can just go for a walk. Okay. That's it. Thank you. I know I ran through a ton of information and I'm sorry I've taken up so much time, but I hope this has been helpful for everybody.
Thank you, Dr. Cremin. That was so informative. Okay, now we're going to dive into a little more of the nutrition piece. Okay. And I'll go through more quickly some of the symptoms since we discussed a lot of those already, and we'll kind of dive into weight management since I know that's a big question for everyone. Just a reminder, obviously, this is not meant as a replacement for medical advice, and as Dr. Kremen mentioned, definitely discuss all changes with your primary medical team. Today, I'll go through some of the nutritional strategies for some of the symptoms that we've discussed so far this evening, and I'll dig in a little deeper into weight management and healthy meal planning and build upon kind of some of the foundation that we laid in our last presentation. So just to give you a little extra nutritional things that you can think about, diet-related things. As Dr. Kremen mentioned, a healthy weight is really helpful to prevent hot flashes. So those who are BMI greater than 30 do have an increased risk. So definitely managing your weight with healthy diet and lifestyle. We'll go into some great tips for that in a moment. Keeping yourself adequately hydrated, limiting caffeine and alcohol, spicy foods, exercise, a lot of the same things really are very helpful throughout this transition. Managing your stress. A magnesium-rich diet can also be helpful, and I'll go through some food sources in a moment, as well as food sources of plant estrogens, which mimic the way estrogen works in our body, but they're found in plant foods, and there's different kinds of plant estrogens. Soy contains isoflavones. You can find them in tofu, tempeh, edamame, soy milk, soy yogurt. Flax seeds are great. Great thing to include in your diet, a couple of tablespoons a day, and they mix well in a lot of different things. Smoothies, yogurt, salads, you can really, and they have such a delicate nutty flavor. They're really delicious and they're rich in lignans. And then cruciferous vegetables, which includes broccoli, cauliflower, Brussels sprouts, even broccoli sprouts, which is kind of like baby broccoli, is a really great concentrated source of lignans and other really powerful chemicals found in cruciferous vegetables. So I see a lot of people kind of try to add more of those foods to help increase these beneficial phytonutrients in their diet during kind of perimenopause and menopause. And then for sleep disturbances, I know we went into a lot of this already, obviously limiting caffeine, but I do want to point out that there also can be hidden sources of caffeine and things like energy drinks, having chocolate too late in the day. So just kind of be mindful of the beverages and products that you're consuming to make sure you're not getting caffeine in other ways that you're not necessarily sure of that could be impacting your sleep. And of course, limiting alcohol, and your sensitivity to alcohol does change during menopause. So definitely be mindful of that. And especially too close to bedtime can really impact your true restful deep sleep. Definitely avoid eating a large meal close to bedtime. And when we do encourage hydration, we want your hydration to really be spaced out well throughout the day. So I know all of us have probably been in the bucket where maybe we weren't as good as drinking earlier in the day, and then we're really thirsty later on in the day, and then we drink a little too much water before bedtime, and that can tend to keep us up. So just be mindful of that, really, to space it well throughout the day. Of course, herbal teas have a nice calming effect, can help with sleep. Chamomile, lavender, or even a blend of both, I've had real success with. And then, of course, magnesium-rich foods, which include dark leafy greens, whole grains, legumes, fatty fish, nuts, seeds, are all great for inducing a nice restful night's sleep as well. You can also discuss with your doctor if a magnesium supplement would be appropriate, but food forms are always the best, and you always start with the food form first. For mood fluctuations and brain fog, as Dr. Cremin emphasized, definitely a foundation of a healthy diet is really important here, avoiding high sugar foods. These cause large fluctuations in energy, mood, cravings. You kind of get that big sugar rush and then a quick crash. So when you're predisposed to having fluctuations in your mood and just that kind of mental fatigue, those kinds of foods can definitely make it worse during perimenopause and menopause. And also avoid overeating processed foods, high sugar foods. Really want to focus on a nice, healthy foundation of nutrient-dense plant foods, and we'll go through more of this in a moment. In addition, foods that have a lot of omega-3 fatty acids, whether from an animal or a plant source, are also really good for your mood and your brain. So things like fatty fish and salmon, tuna, mackerel, wild is always the best form. Seeds like the flax seeds I mentioned, also chia seeds, hemp seeds, and nuts such as walnuts. Walnuts are one of the best sources. If you think about kind of a half of a walnut, it kind of looks like a little mini brain. I always like to say that kind of nature helps point us to what foods are beneficial for. So walnuts are really, really good for your brain function. And now to kind of dig in a little bit more to the weight gain, which I know is often one of the most troublesome side effects that people come to me for, because and a lot of times it's people who maybe had never experienced weight gain in their lifetime. And all of a sudden they kind of reach around age 40 or a little bit after that, and it hits them very unexpectedly. Well, believe it or not, more than 80% of people are in that boat during the transitional period of perimenopause to menopause. And as Dr. Cremin mentioned, it's a lot of hormonal changes, shifts in body composition. We're also noticing a decline in our muscle mass, and we lose a certain percentage of our lean body mass each and every decade. So as we're getting into the 40s and 50s and beyond, that makes it more challenging to keep our metabolism up and can also promote weight gain. And of course, there's so many other things going on in this time period. If you're dealing with lack of sleep, a lot of stress, reduced physical activity, like we mentioned, can definitely all contribute to weight gain. But I would like to think about kind of rather than a lot of people tend to focus on the numbers and maybe the fact that their body shape has changed. But I like to think of the nutritional strategies during this time period more as a way to fuel your overall well-being, to give your body the nutrition that it needs to live a long, healthy life. So we want to eat nutrient-dense foods that are full of antioxidants and phytonutrients. These are what's going to make a really big difference. And we're prioritizing health for that reason, with just small positive changes to support our body, help ourselves feel well through this transition. And I think if we naturally focus on that bigger picture, then the weight management and kind of the healthy changes will follow. So it's kind of like changing our perspective a little bit rather than just focusing on a number. So some kind of good overarching strategies for weight management in this time frame. I usually encourage people to avoid crash diets. So whereas maybe those have worked for us in the past when we were younger, our metabolisms are not as responsive to that in this time period. So we definitely want to avoid chronic under eating, low calorie diets, chronic dieting, crash diets. These can actually further impact your hormone levels and decrease your metabolism, making it even harder to lose weight during this time period. You also want to embrace the quality of your food. And I know we've emphasized this a few times already. It's really about the nutrient density. So rather than overly focusing on kind of calories and a certain level, you really want to make the good foundation of your diet as healthy as possible. It's also important to recognize that it's not an all or nothing approach. It's really important to have a healthy relationship with food. Like I had on that previous slide, thinking of food as your fuel, thinking, and as I mentioned in our last presentation, kind of thinking of the healthy phytochemicals and antioxidants in your diet as your body's natural detergent to protect your cells from damage and prevent chronic inflammation and reduce your risk of chronic disease. And there definitely isn't a magic bullet either. I know on Instagram and wherever else, there's always the latest and greatest supplement or superfood, or it's pretty crazy to see all the different things that come out these days. But the answer is if it's too good to be true, chances are it is. So there definitely isn't a magic bullet that exists. We really want to take a lifestyle approach, a healthy lifestyle that includes a balance of healthy eating, stress management, and physical activity. And remember, we want to make our diets sustainable. Food is meant to be nourishing and enjoyed at the same time. So we'll talk about some more ways to do this in a moment. But first, a few kind of different and fun ways to fit in physical activity. And as Dr. Cremin mentioned, it doesn't have to be like breaking a sweat or running a marathon, right? It's fitting in manageable ways to stay more active. And so I just tried to put together some unique and different ways that maybe might work for you at this phase in your life. Things like gardening, scheduling different kind of chores throughout the house throughout the week, or maybe take up riding a bike that's been in the shed for a long time, or hiking on a trail, taking a dance class, like belly dancing, something fun or different maybe that you haven't tried before, a new fitness class, or hula hoop. Actually, hula hooping is really good for your core and your abdominal area. Even investing in a mini trampoline. I actually have a mini trampoline that I try to do for at least 5 or 10 minutes every morning, because jumping is really, the gravity of that is really good for your bones during perimenopause and menopause. Or there's so many great exercise apps or programs to help you motivate you and to promote fitness, and also to help you stay on track. So now let's get into some strategies for healthy meal planning. Here we want to aim to include a good variety of wholesome, real ingredients, rely less on the processed foods, and we want to use a lot of colorful plant foods that have a lot of fiber, phytochemicals, antioxidants, rich in nutrients. So we're talking fruits, vegetables, whole grains, beans, nuts, seeds, and lean protein. We want to generally aim for most people. Now, this can vary based on your own individual nutritional needs, but most people need at least roughly 20 grams of protein per meal at a minimum. And this is especially important for breakfast, when we tend to be in a rush and we don't usually eat enough protein at breakfast. And then that kind of catches up with us later on in the day, and we tend to be more hungry. And if we had had a more balanced breakfast, that tends to reduce cravings later in the day. Good sources of protein come from chicken, turkey breast, wild-caught fish, eggs, beans, nuts, tofu, low-fat dairy. And then we also want to aim for a good amount of dietary fiber. Most Americans only eat or roughly 10 grams a day, so less than half of the amount that we need. Now, 25 may seem like a lot, especially if it's not something you typically focus on. So you can roughly make that about 8 grams per meal. And you could build up slowly. You generally really don't want to add too much all at once, especially if your body's not used to it, because then you can get some digestive side effects. And especially make sure to drink plenty of fluids if you are increasing your dietary fiber, just to help promote regularity as well. And remember, naturally including more healthy foods and plant foods does automatically provide a diet that is very rich in fiber as well. And a lot of these symptoms that we talked about earlier on, like hot flashes and sleep disturbances, a lot of that can be worsened by a diet rich in processed foods and added sugars. So definitely be more mindful of the added sugar in your diet. Read labels, check for hidden sugars, not only looking at the nutrition facts where it says the grams of sugars, but also looking at the ingredient list as well to make sure that sugar or some form of sugar or high fructose corn syrup is not in the top portion of the ingredient list, because that usually means that it will have, more sugar than you need. So definitely be more mindful of that as well. And we also, in talking about healthy carbohydrates, want to try to limit our refined carbohydrates, things like white rice, white pasta, things that don't have added fiber. So we want to choose more whole grain forms of things and kind of have our carbohydrate intake be more in the earlier portion of our day when our bodies are best able to process it. And this actually becomes more important as we get older. And lastly, we also want to think about the timing of our meals. So I like to say, kind of try to eat with the daylight, eat with the time of the sun rising and setting. And that generally is a better way to assist your body with the natural processes and natural fluctuations in your hormones and body's chemicals that promote digestion. So some people call this time restricted eating. Some people call it intermittent fasting. There's different kind of schools of thought and ways that you can do it. So definitely speak with your medical team or your dietitian to see if that would be an approach that makes sense for you. But for general purposes, just kind of following that schedule and not eating too close to bedtime is beneficial for everyone. And then I like to say the 80-20 rule. So eating a whole foods, nutrient-dense diet, rich in plant foods 80% of the time, and allow time for indulgence 20% of the time. Because of course, if we deprive ourselves too much or we have overly restrictive diets and meal plans, those not only have physiological impact on our bodies, especially through perimenopause and menopause, but also psychological impact as well. So life is meant to enjoy, and foods are meant to enjoy, and everything can fit in balance and in moderation. And I also like to encourage people, rather than focusing on just a number on the scale, where you may have a goal weight that maybe isn't appropriate for your stage or age in life. You have to think realistically of other health victories, what I like to call non-scale victories, that make sense and will still give you a very good health benefit. So things like trying a new recipe that's healthy, eating out less, maybe eating more home-cooked meals. Maybe you've never really been great at meal prep, so a good goal for you might be to meal prep for the week, or experiment with different herbs and spices rather than using a lot of sodium in your foods, or try to find new activities that you enjoy as a family to stay more active. And you really want to just celebrate small wins and set realistic goals for yourself and be kind to yourself. So when we think about like kind of a good picture of what a balanced plate looks like, I like to see a lot of good color and variety. So we've got plenty of healthful plant foods here, obviously. We've got nice lean protein. We've got good wholesome grains. You could see a little portion of quinoa there. So when we think of our balanced plate, we want to have plenty of plant foods. We want to have a nice portion of lean protein, but we don't want like half of our plate to be the protein, right? So a typical American diet is kind of a big hunk of steak with mashed potatoes and like green beans, right? So we want to kind of rethink that. And we kind of call this the new American plate, right? The healthier American plate, that the foundation is more plant foods, lean proteins, and whole grains. And lots of color. We want to eat the rainbow. So I figured I'd leave you with some good healthy meal suggestions just to kind of help you, give you some ideas. So for some healthy breakfasts, we have avocado and toast with a nice egg. You can do overnight oats. There's lots of great recipes out there. You can make them the night ahead, leave it in the fridge. You can even put some extra protein powder in there if you wanted to make it well balanced. There's superfood smoothie with an added protein powder for those who like beverages in the morning or something that's quick or on the go. There's some great protein, whole grain protein waffles out there now that you can have with some Greek yogurt. You can put some flax on top of that. It'd be really tasty. Scrambled eggs with some veggies, so kind of like an egg scramble, and you could do that in a whole wheat tortilla. That would be great to make ahead, and you can freeze it and then have it ready, ready to kind of just microwave when you need it. Oops, I think I missed lunch. Okay, so lunch, we have quinoa bowl with beans, tofu, and veggies, kind of like, you know, the Buddha bowl concept, similar to the picture that we just had on the screen. You could do a turkey and hummus wrap on a whole wheat wrap, try to get more fiber in that way. Grilled chicken or salmon over mixed greens, or a lentil vegetable soup, or even lettuce wraps are great. So a tuna salad with lettuce wraps. And then for dinner, oops, sorry, my screen jumping. So for dinner, grilled salmon with roasted vegetables and brown rice, grilled chicken, and quinoa stuffed, ground chicken rather, and quinoa stuffed peppers. It's really delicious. You could do turkey meatballs with zucchini noodles, tofu stir fry with veggies, or baked chicken breast with sweet potato and asparagus. Some of this stuff you can even, make ahead, make extra free so that you have readily available on a night, maybe when you don't have as much time to cook, to just kind of plan ahead that way as well. It's a great technique to always have healthy foods available. And remember, frozen produce is a great shortcut. They sell brown rice, quinoa that's frozen already, pre-cooked. All you have to do is kind of microwave it or add it to your dish. Zucchini noodles, they have all kinds of veggie noodles now in the freezer section. So all of these things definitely don't take as much time as they once did. So there's lots of healthy shortcuts that you can take to make healthy eating doable. So I know we've covered a whole lot today, so I definitely, encourage you to, rewatch any part that maybe you really wanted to pay attention to, or to go back if you have any questions. Of course, you're always welcome to reach out to Dr. Cremin or myself as well. But in summary, I really just want to leave you with, some encouragement. Each phase of menopause does have its own challenges, but understanding the journey, and of course, we're here to help you do that, does help you manage symptoms and, most importantly, make informed choices to embrace this transition and be knowledgeable, prioritize self-care. So here is my contact information for my Westminster nutrition practice. So feel free to reach out to me anytime. And just a reminder too, we have our final presentation coming up in March, which is focusing more on disease prevention. So we'll go over general preventative care and including the necessary prevention and screenings for optimal health and longevity for things such as cancer prevention, diabetes, heart disease, etc. So definitely another one that you definitely won't want to miss. And of course, if you did miss part one or want to go back and rewatch any of these, you can check them out on the Edith Real Memorial Library YouTube channel. So they are available there as well. So thank you, Luca, for recording these and making these available to everyone. And lastly, just some resources as well. The great book that we mentioned last time is The New Menopause by Dr. Mary Claire Haver. She also has a really great nutrition book as well. And of course, the American Dietetic Association is always a great site. They have a great consumer-facing site with great resources and handouts for anything nutrition related as well. So I will open the floor to some questions now. I'll stop sharing.
We have one question here from Eileen. In the absence of hot flashes, does coffee negatively affect bone density? Is it best to avoid coffee even if you do not have hot flashes? So coffee by itself, and Jessica, I'll let you weigh in here too, but it's the caffeine in general from any source, not necessarily just coffee, that impacts bone density. So definitely can play a role. Do you have other information on that, Jessica?
Yeah, and I generally take it on an individual approach. So, Eileen, I just recommend discussing it with your healthcare team. If you have a kind of a osteopenia, which is the early stages of bone loss, then it might make sense for you to look at your caffeine intake and cut Generally speaking, and Dr. Cremin, let me know if you want to weigh in. I generally say, roughly 1 cup, 8 ounces is usually fine. It's usually in excess of that where I really start to look more closely at how that might be impacting other areas of the body as well. Some people are more sensitive to it, even for things like heartburn, reflux, and so on and so forth. So,
Want to talk about cup size, though, too. So a cup of coffee is 5 to 8 ounces, not the big giant,
yeah,
32-ounce mugs that we see people driving around with all the
yeah.
time. So that would be considered essentially a pot of coffee. So,
Yeah.
but yeah, the caffeine reduces calcium absorption from all of your sources, and so definitely something that you want to limit.
And if you do like the taste of it and you drink it more often than you or drink more than the 8 ounces, you could always switch to decaf. Just do so slowly. If you're used to a lot, obviously you want to kind of wean yourself off of it so you don't get a headache. Um, but you could always switch to decaf forms. I don't notice the difference in taste, but people tell me they notice the difference. I don't know. I don't notice the difference between decaf and caffeinated. And there's some great dark roast decafs that I
Oh,
really.
yeah, for sure. So another question here about clotting disorders and hormone replacement therapy. So generally, it depends. I would say on a case-by-case basis. So definitely something that you would want to discuss with your hematologist if you have a clotting disorder, and your primary care physician if you have a clotting disorder, to determine if in your particular case it would be an option for you. So both estrogen and progesterone in general have been shown in some instances to increase risk of blood clots, but the form of estrogen and progesterone, which I didn't get into all the nitty-gritty details on the different forms of those medications, some types can increase risk over other types. So definitely something to discuss with your physicians.
One question I had was like in the in the slideshow it said uh, there might be chances of the cholesterol going high, the blood pressure going high. Is that a temporary phenomenon, or is it the start? What is that? Or and even the diabetes, right? So these are all starting, or
It's
is a temporary phenomenon that will just settle as the menopause is like I don't know.
temporary. A lot of
Okay.
these things, I'm going to talk a little bit more about that in our next session, but uh, luckily, a lot of the lifestyle approaches that you can take to reduce your blood pressure also reduces your cholesterol, reduces your risk of heart disease. And those include increasing exercise, reducing fat intake, increasing fiber. All of those things can play a role, and it's not temporary, unfortunately.
So even the chances of the endometrious cancer, that is also like that is also huge, is it? That's how it is during the menopause, premenopause time.
Huge risk of endometrial cancer. The risk in the general population, the risk of endometrial cancer increases when women are so when we have our normal cycles throughout our lifetime, we have
Hmm.
estrogen, but we also have progesterone, and then we have a menstrual period. We bleed, we shed. When we bleed, we shed the lining of the
Hmm.
endometrium, the uterine lining. So in hormone replacement therapy, we want to mimic that shedding. So, or protect the uterus with progesterone, and not just allow estrogen to impact that uterine lining. Does that help? So that's where the risk of endometrial cancer comes.
Okay.
We don't want, for women who have a uterus or
Hmm.
people with a uterus, we don't just want to use estrogen. We need to use progesterone, or in the case of that medication, Duavi, that is a non-progesterone medication that also helps protect the uterus as well.
Okay. All right. Thank you very much. Yeah.
Okay, I saw the
Way to
fasting.
manage perimenopause. I don't know, Jessica, I'm going to toss that one to you.
So, once again, it is individualized. There are intermittent fasting styles that might be beneficial, like I mentioned, kind of that time restricted eating within a certain window that can help your body to kind of reset overnight and potentially prevent a lot of the fluctuations in blood sugar that can impact mood and symptoms related to weight gain and things like that. So in some instances, yes, but you have to be careful because your metabolism is also lower as you get older. So if you do that for too long and you have let's say you're somebody who's not eating breakfast until 11 and you have a very small window that you're trying to eat, I do find sometimes that in some patients it backfires a little bit because it ends up kind of slowing down your metabolism because it's very hard to eat enough within that window. And then therefore you're kind of in a calorie deficit. You've got a lot of cravings because you're hungry because you're not eating for a long time. And so sometimes that can backfire. It may work on the short term, but it's definitely not a long-term thing. There's of course a lot of different other more aggressive forms of fasting that we could talk about on a case by case basis, but in general, that's the one that I see people do the most. And I find that the most effective form is really just a 8 to 10 hour window. That's a normal, like I said, eating within the daylight. Anything shorter than that, where you're really going a very long time without eating, you run the risk of kind of slowing down your metabolism too much. Because part of the benefits of eating regular meals and snacks, especially earlier in the day, is your body has the most kind of optimal form of digestion and kind of chemicals. At that time, your pancreas is releasing adequate insulin to get the blood sugar into your cells. And so when you kind of shift eating to further later in the day, sometimes that does make it harder to lose weight and can cause increased cravings. So just be careful. In certain instances and with kind of appropriate management, it can definitely fit.
Next question, is it possible to have systemic estrogen therapy given topically? I heard this is better than oral form to avoid clotting. And then if so, when opposing progesterone is indicated with the uterus, I heard that topical progesterone is not enough and it needs to be oral in order to avoid endometrial hyperplasia. Is this correct? So absolutely, you can have systemic estrogen therapy generally given in a patch form. So, and they're primarily are estrogen patches in a number of different dosing options. There is oral estrogen as well, but the topical estrogen patch is definitely preferred. We do have patches that include progesterone as well. Unfortunately, they tend to be quite expensive, almost $300 a patch, versus using a patch for your estrogen, which is about $15 or $20 for a month's supply, versus the $300 for a month's supply of the combined patch. Or you can also take oral estrogen. So, sorry, I lost track of what I was saying there. But so the only available topical progesterone is in that patch at adequate doses. But some people try to use compounded progesterone, and those creams don't provide enough progesterone for uterine protection. Um, I think I answered all the questions. Is that helpful?
Great questions, everybody.
Yeah, very good questions. Good. You're welcome. Any other questions?
And if you forget something, we could always discuss it next time as well. So
Thanks everyone for showing up. And this has been great. Really some awesome questions tonight. Really grateful for those to help clarify some things. And we wish you all the best and hope to see you next month. Take care.
have a great night, everybody.
Thanks. Bye-bye.